Okay now. All right, so welcome back to our sixth ECG round. Tonight we will talk about supraventricular arrhythmias, and we will review different cases and particularly going through different diagnostic ECG. All right, let's start with this dog. This is a Labrador Retriever, male, 5 months old, and he was referred for acute dyspnea and tachyarrhythmias revealed at clinical examination. This was the echocardiography, the X-ray, and as you can see, there was cardiomegaly, as you can see here. So there was an increase in longitudinal and transverse. There was venous congestion and pulmonary edema. So we have alveolar and interstitial pattern. And this was the ECG at arrival. So as you can see, we can see some sinus beat, just like this one, and this one. And after each sinus beat, we can see a runs of supraventricular, very likely a supraventricular rhythm. As you can see here, it's a narrow QRS complex. It's a little bit different compared to the sinus one, but still has a very, very similar morphology. This is the usual 12-lead ECG. There is a problem with this ECG. And the V1 is placed in the right first intercostal space, the one that we published, and then V2, V3, V4 are well positioned. I think V5 and V6 are not, because probably has been placed a little bit too close to on top of the heart, so too dorsal, and that's why are so tiny. Remember that precordial are always should be considered unipolar, so they are reading exactly when they are placed on top of the right position of the heart. So let's start to analyze this ECG. First of all, again, these are sinus. And if we look at the sinus beat, just like this one here, you can see that P wave is prolonged. So there is a duration that is more than 40 milliseconds in dogs. And when this duration is so prolonged, one possible diagnosis is the presence of interatrial conduction interruption or delay. You can say that because there is also a bifid appearance. Then we can move to the area where we have this supraventricular rhythm. So the heart rate is very, very fast, 338 beats per minute. The duration of the QRS complex is 56 milliseconds. So it's it should be considered a narrow QRS complex tachycardia. If you look at the RR interval, are not completely irregular. We have what we call cycle length irregularity. As you can see here, there is a variation of the RR interval here. It's a slight variation, but they are not completely regular. For example, you have completely regular RR intervals in reciprocating tachycardia, for example. That's very, very important to remember. When you have this type of variation, so cycle length irregularity, I think we should completely rule out, in most of the case, orthodromic atrioventricular reciprocating tachycardia. We cannot rule out permanent junctional tachycardia. So the other type of reciprocating tachycardia with a slow conducting retrograde accessory pathway. So it's a narrow QRS complex tachycardia. So where is the atrial deflection? So it's important to look at the rate and compare it with the period where we have a sinus beat. So in our our idea was that, as you can see here, there was a positive P prime here in the ST segment. And it was inscripted variable from this area here to this area here to this area here. So it's positive in inferior lead, so 2, 3, and AVF. It's negative in AVR and AVL, and it's the X, and it's almost positive in lead 1. So the axis of this atrial activation is superior to inferior on the frontal plane. So this is probably an activation arising from the roof of the atrium, and very likely since the lead 1 is positive from the roof of the right atrium. And so with this type of polarity, we can rule out orthodromic, any reciprocating tachycardia, actually, because, you know, reciprocating tachycardia has a negative activation arising from the floor of the atrium. So superior to inferior, left, no, sorry, because it was negative here, sorry. It was this one because it's compared to this. This is my mistake. So it's a left to right axis. So it's arising from the roof of the left atrium. So because here is tiny, but if you compare this activation that is positive here and here, then you can see that is negative up here. Remember that the lead 1 is the lead that tells us if it's right or left. So when it's flat or positive, it's coming from the right. When it's negative, just like in this case, it's coming from the left. So in summary, we have a narrow QRS complex tachycardia, a regular RR interval with cycle length irregularity, and we have sign of atrial activation with a P prime with a superior to inferior axis left to right. So our idea now is that it's probably a focal atrial tachycardia arising from the roof of the left atrium. So very likely either the pulmonary veins or the left atrial wall. So why we still consider accessory pathway mediated tachycardia as differential? Because when you are 100% sure that what you see is the atrial activation, and as you saw, also I did a mistake. So sometimes it's not so easy to be 100% sure about the atrial activation. So in our experience, when you are 100% sure that the atrial activation is positive, you can, in inferior lead, you can rule out reciprocating tachycardia. But if you are not, it's better to still keep it in your differential list. In this particular case, I think at least in the inferior leads, you can see a positive lead. The other thing, again, that can help you in ruling out OAVRT, so orthodromic atrioventricular reciprocating tachycardia, is the cycle length irregularity that you can actually have in permanent junctional tachycardia, but not in orthodromic atrioventricular tachycardia. So we published in 2008 this paper that made the differential between these two, so focal atrial tach and OAVRT. And as you see, the presence of cycle length alternance is always a sign of focal atrial tach. Usually when you have pre-excitation, you have the diagnosis already of reciprocating tachycardia, but you remember that we have 70% of the cases of accessory pathway, they do not have pre-excitation. And then another thing that can help us in ruling in focal atrial tachycardia is because the P prime was close to the T. Usually in OAVRT is negative in inferior lead and in the ST segment with a short RP prime. So our diagnosis is focal atrial tachycardia arising from the roof of the left atrium. Roof of left atrium, again, the area can either be the vein or the atrial myocardium. This was the echocardiography of this dog. As you can see, it's a very young dog with a huge left atrium. You can see that the mitral valve leaflet are not normal, and there is a volume overload. So our suspicion here is, okay, maybe the tachycardia can induce some dysfunction, but we also have to consider if the mitral valve is completely normal. So we have to look carefully and to understand if this is just a dilation of the annulus or if there is also alteration of the mitral valve leaflet. This is the huge left atrium, huge left auricle here. And so we treated this animal for pulmonary edema, and these are the X-ray post-treatment. So as you can see here, we have a reduction of the silhouette, probably due to the presence, to the use of diuretics. Here you can still see the dilation of the left auricle and a reduction of the silhouette. Obviously, the edema resolved. This was the Holter. That's an interesting Holter in my opinion. As you can see here, the distribution of the RR interval is not normal. So you have period where you see the purple dots here are dots indicating the presence of supraventricular rhythm. If you look here on the full disclosure, you can see that we always have sinus beat followed by a runs of focal atrial attack. Sinus beat, nothing. Sinus beat, one extra beat. But as you can see, we have always the focal atrial tachycardia always starts after a sinus beat. That's always like that. You can have a sinus beat without runs, but when you have a runs, it's always related to the sinus beat. Another interesting, important feature is that the coupling interval after the sinus beat, the coupling interval is variable. So you can have, you see, shorter, a bit long, or longer. So it's interesting, this behavior, because it's very, very suspicious of trigger activity. So very likely EAD, early after depolarization, and very unlikely DAD, so delay after depolarization. So it's very important because focal atrial tachycardia can be induced by different arrhythmogenic mechanisms. One is, the most common is enhanced automaticity, abnormal automaticity, micro reentry, very rare, at least in dogs, and then you can have the EAD or DAD. Remember that from the pulmonary veins, it's very common to have early after depolarization. Here, other example, another point, when the rhythm decreases, so there is more bradycardia, you can see there is more trigger activity. So our final diagnosis is focal atrial tachycardia, probably due to a bradycardia-dependent oscillation of the action potential, so EAD, so early after depolarization. And you can see a zoom here in the area where we had a lot of these runs. You can imagine that these runs can induce a deterioration of the systolic function. So this is very important to remember, that it's not just the rate, it's also the irregularity of the rate inducing this type of loss of systolic function. So we decided, since we believe, or we believe that it was EAD, we decided to use ivabradine. You know, ivabradine is a drug that is working here throughout the inhibition of the IF channel. Has been shown in human that some ectopic foci can be triggered by the activation of this channel, this IF channel. So it's very important that in some of these tachycardia, ivabradine can be an option. And we actually have several cases where ivabradine worked, but other cases where it did not. So this is the rhythm that we see, and with the systemic artery. As you can see here, you can actually see quite well the pulse deficit. You see that these pulse follow this normal beat. Then we have, for these two beats, a pulse deficit. Then you have another normal beat, pulse deficit, normal beat, pulse deficit for these three, and so on. So you can imagine the irregularity of this particular type of rhythm and how it can impair systolic function. So this is quite interesting. So we decided to do the mapping, and as you can see from the mapping of this tachycardia, after going through the interatrial septum using a transeptal puncture, we could see that this is the sinus beat, so this is the atria, this is the ventricle, this is the ectopic beat, so this is the atria, and this is the ventricle. Look the activation, how different is. Here is going right, so coronary sinus ostium, to left, coronary sinus distal. Here is going left to right, so it's going from the left atrium to the right atrium. So our suspicion that this was a tachycardia arising from the left atrium was correct. And so the tiny P wave now with the endocardial mapping, we can actually be 100% sure that this was a tachycardia arising from the roof of the left atrium. So we also had, during the mapping, some runs of atrial fibrillation, and so we need to do a cardioversion, try to reobtain the sinus rhythm. And this is a zoom that shows you quite well the mapping of this ectopic beat. So again, this is the his, so we are anterior. This is the coronary sinus ostium, so posterior. And what happened is that when you have the ectopic beat, look how early you have the activation of the atria. So it's starting left to right, left to right. So this is even less early, this is earlier, so you see it's concomitant to the his. So where you can find focal atrial tachycardia in human are mainly at the crista terminalis, here in the coronary sinus ostium or in the wall of the interatrial septum. Other very, very common sites are the pulmonary veins ostium and in the left auricle or the right auricle. And these are the area reported. So how we do transeptal puncture? Transeptal puncture can be performed in this way using a long introducer that is placed in the cranial vena cava, then pulled back and gone into the foramen valley, and then across the foramen valley you can go initially with a wire that is called septal wire. And then when you are sure with this wire to be in the left atrium, you can go with the needle and then with the introducer. And therefore, now you can go left and work on the left side of the heart. And this is how it works. Then, as soon as you are on the left, you go with the electrode and the ablation electrode, and you can move with the, as you can see, is a steerable curve. You can go dorsal, so on this upper part of the atria or on the lower part of the. And this is how we did. So this is the coronary sinus, proximal, distal. Remember that we have early the distal and less early the proximal. So means that it's coming from the left. And this was the catheter placed on the left atrium. And this is exactly the area where on top, on the roof of the left atrium, this was exactly where the ectopic foci of this dog was located. This is what happened. If you look carefully, this pre-echo, you can see that in the time 0, you have the presence of huge left atrium and a reduction of the diastolic diameter because there was a faster rate during the tachycardia. After 10 days post-ivabradine, and this is after 20 days post-ivabradine, as you can see from the rate, we couldn't actually obtain a good control. If you go here and you measure using the Holmer formula, you can actually see that 20 days post-ivabradine, like here, and this was post-ablation here and here. So as you can see, the volume of this, it was 79 at the beginning, was 85, 92 when we use ivabradine. So it was very, very deteriorating. So ivabradine was not controlling. While it becomes 51 and then 40 after few weeks post-ablation. As you can see, now you have a normal sinus rhythm also here with no ablation, sorry, with no reoccurrence of the tachycardia. This is the ECG after ablation, 2 days after ablation. As you can see, we still have some intra-atrial conduction delay. Obviously, we don't have any more SVT because we ablated the spot where the tachycardia was arising. What is interesting that in this dog, despite the presence of a dilation due to what arrhythmic-induced cardiomyopathy, it may be a mild form of mitral valve dysplasia, but in 5 minutes ECG, we can already see changes in the RR interval, suggesting that probably this dog has now a more modulation of the heart rate also with the vagal tone. So the ablation was a key point for this particular case because it could eliminate this tachycardia arising from the roof of the left atrium. This is after 10 days. Look how nicely now sinus arrhythmias reappear. So this suggested to us that probably the component induced of arrhythmic-induced cardiomyopathy, therefore so induced by the continuous and irregular RR interval, was probably the major cause of this DCM in this dog, so this volume overload with loss of systolic function. And look at 10 days now, the sinus arrhythmia at the Poincaré plot is much more visible, and also on the histogram is much more visible, meaning that now we have a good equilibrium between vagal tone and sympathetic tone. 2 days post-ablation, 10 days post-ablation. We really like to use the Lorentz plot also when we do 5 minutes ECG, because we believe that if you do 5 minutes ECG in a normal dog, you have some changes of the RR interval. Remember that this is RR, this is RR plus 1, so the following RR, and so here is tachycardia, here is bradycardia, here are RR interval long followed by short, and here are RR interval short followed by long. So this means that we have sinus arrhythmias. All right, so Manuela, is there any question regarding this case?
Yes, there is some questions. So the first one is a clinical question. So is focal atrial tachycardia congenital or acquired disease? And what should we look for as a primary cause?
Okay, this is an interesting question. In this particular dog, we also perform biopsy, because when you have focal atrial tachycardia, you can have underlying myocarditis, usually chronic myocarditis. So in such a case, we do endomyocardial biopsy and molecular biology to look for bacterial or viral genome. Another option are channelopathy. For example, this week we did an ablation in a crystal focal atrial tachycardia in a 6-month-old Rhodesian Ridgeback. As you know, Rhodesian Ridgeback can have the mitochondrial cardiomyopathy due to a mutation of the ILQ1 gene, and this cardiomyopathy can induce SVT, so focal atrial tach, AV block, and ventricular arrhythmia with sudden cardiac death. So it's very important to remember that the channelopathy and myocarditis are the most common. So we really suggest to do biopsy when you do the ablation of this foci.
Okay, then one question about the QRS complex. If you go back to the first ECG, in your opinion, why the QRS complex, the R wave is taller if associated with P wave and is less tall during the runs of supraventricular tachycardia?
All right, this is another interesting question. So remember that this is a EAD, so bradycardia dependent. So what happened? The action potential duration is usually related for the QT memory to the previous 5 beats. So for example, this QT depends on these previous 5 beats. So what happened when you have a longer pause in the previous 5 beats and then suddenly you have an increase in the rate, so it's a sudden increase in the rate, just like here, you can have aberrancy. So the option is that this is a form of aberrancy in phase 3 aberrancy. Then when it's more than 1 beat, it's called linking, phase 3 linking. Because the other option is that what we call Brody effect. So the Brody effect is a change in the amplitude of the QRS complex related to the filling. So when you have more filling of the ventricle, you have a taller R. When you have less filling, you have less tall. And since these beats are very variable, also Brody effect can be considered. So either both Brody effect or phase 3 linking. This is the two more likely differential diagnoses.
Okay, just one question about P wave. So if you consider P wave in the first ECG and you compare this P wave with the P wave 10 days after ablation, the last P wave is probably reduced in duration. So what are your differential in these two different P wave?
Okay, again, this was the intra-atrial conduction delay. So you have a bifid P wave. So that means that you have a remodeling of the atria. Remember that this rapid heart rate in the atria can remodel anatomically, so fibrosis and inflammation, and electrically, so reduction of the action potential duration and of conduction. These are, everything is pro-fibrillatory. So what happened after, if we go to the end of this ECG after ablation, here we go. You can see that the P waves is getting a little bit shorter here, here, and here. That means that we obtain some, and if you go here even more, so it is actually, if you measure now this P wave is a normal P wave, that means that because we stop the tachycardia, we obtain reverse remodeling of the atria. So he's a young dog, so the amount of fibrosis, apoptosis, and inflammation is not as bad as this happening in an old dog. So that's probably why this dog has no, after remodeling, it could have it can go back to a normal P waves. Remember that this dog has also atrial fibrillation during the mapping that needed cardioversion. That means that the atria were remodeled. So there was a reduction in the action potential duration, slowing of the conduction, and therefore there was this possibility to have atrial fibrillation and to maintain atrial fibrillation.
And in your opinion, can be this atrial delay also correlated with the pressure inside the left atrial chamber?
It can be, because atrial stretch can actually induce alteration of the conduction and remodeling. So it's a combination, because the atrial stretch together with the fast heart rate are the basis to have remodeling in the atria and the ventricle. This dog, we just have back the biopsy, and he had sign of myocarditis, because we found in chronic myocarditis, now is a common feature of chronic myocarditis is the presence of endocardial fibrosis, endomyocardia, but mainly endocardial fibrosis. So it's an important key point, because it's very similar to the restrictive cardiomyopathy, I mean, at least from the histological point of view.
Okay, thank you very much. We can move to case 2.
All right, this is a case that we saw a few days ago. This is a Chihuahua, female, 10 years old. He has a severe mitral valve disease, and he was treated at the beginning by the referring vet with furosemide, benazepril, spironolactone, and pimobendan, and was referred because of acute onset of weakness and tachyarrhythmias. And this is the ECG. I just leave just 1 minute for you to have a look on this ECG. As you can see, we have narrow QRS complex tachycardia here, very, very fast. But what is interesting, we can see the presence of this atrial activation that you can see quite well in precordial. And then you move up here and you can barely see here and here and here. So our first differential is this a sinus tach? So it's a sinus tachycardia. I wasn't sure 100%, because then when we go down here, look how nice the precordial show you this finding. So if you go here, particularly at the beginning, see there is another atrial activation here, 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 and here. So the first impression is this a sinus tachycardia wasn't correct, because we have another atrial activation here. So we have a supraventricular tachycardia with 2:1 AV conduction ratio. This is very, very suspicious of atrial flutter. It's very important that atrial flutter in dogs is usually is the only tachycardia, supraventricular tachycardia, that can be conducted with 2:1 AV relationship. This is an important part to remember. So look how nice the Poincaré helped us in the understanding, because you see now that you have line of block in the 5 minus ECG, meaning that there is a tiny variation of the RR interval related to a change in the AV conduction. And this is very helpful if we had a suspicious of sinus tach, and then you do the 5 minutes ECG, you see that you have line of block. There are usually, in case like this, AV relationship variable. Particularly, this was a 2-to-1 AV conduction ratio. And this is the halter of this dog. We started in this dog, so this was a sustain. Remember, another important key point of flutters is that flutters are usually incessant. It's very, very rare that a flutter is paroxysmal. So in such a case, we give in this dog sotalol. We started with a very low dose. We know that you need at least 2 mg/kg to have a class 3 effect. And to stop a flutter, you need an heat-sink blocker, so the sotalol with a class 3 effect. But we weren't sure that this dog could handle the sotalol, and so we started low. And see what happened. Here we have a 2-to-1 conduction ratio, so it's kind of a line here. Then after a few hours, you see now that the sotalol did not stop the flutter, but it increased the AV conduction ratio. So you have now a period where the conduction is more than 2-to-1. Here is actually 20-to-1. And so you see here now that the flutter is lower, but it's not stopped. And sotalol, if you have a normal systolic function of the right ventricle, can be used, but if you have a bad systolic function of the right ventricle, it's better not to use it. And this is the dog this morning after 2 doses of amiodarone, 15 mg/kg. So we use a loading dose, and with this loading dose, we could obtain a cardioversion. So we prefer to start with sotalol because the dog wasn't eat quite well. We were kind of worried about the side effect of amiodarone, but amiodarone instead, after just 2 doses, induced cardioversion. Now we have to check over time if this dog can handle amiodarone. So what we do after is to reduce the dose of amiodarone at 7.5 mg/kg twice a day. And most of the dog can handle this dose chronically. There are few dogs that could not. One is Dobby. Remember that Doberman, I mean, we do not use amiodarone because you can have severe side effects. All right, so this was another recent case about the atrial flutters in small breed dog with mitral valve disease. It's not a common feature, but can happen. And another important part that all the flutters that we handle and we map and ablated are right-sided. So we have now at least the cavotricuspid isthmus dependent, so the typical and typical reverse, and then we have 3 atypical, the right septal, the right atrial free wall, and the cranial vena cava. They are all published, and I already showed you in some other of our meetings. But we could not so far map any left-sided flutter. This is very suspicious to be a left-sided flutter, but we have no proof because, I mean, we suspect that because of the type of appearance of the wave and with the important negative cusp that we think is down here, and also because he has a huge left atrium, and so it's very likely to be the cause. Okay, Is there any?
Okay, thank you very much. So if you consider the tachogram, how do you consider the green dots just on the top of the pink line?
This one here and
Yeah.
here. Yeah, that's a good point. So remember that most of our Holter system has problem with the horizontal resolution. So what happens sometimes, since you see lines of block, this means that one, you could have some changes in the AV conduction that becomes lower. So for example, this one here, this one appear as green dots here, or up here, since was sustained with 2 to 1, it's just that it accelerated here, and so we have problem with the reading. So maybe you read a 1 every other 2 beats, 1 every other 3 beats, and so on. So it can be a problem with the horizontal resolution.
Okay, and did you mention sotalol? So in your experience, the administration of sotalol affects just the AV conduction or also the FF intervals?
That's a good point. Usually, sotalol can interact with all these circuits. So you can have a change in the wavelet cycle length and a change in the AV conduction, particularly because with 1 mg per kg, we are mainly working with the beta blocking effect. So what happens is that you can prolong the RR because there is a slowing of the AV conduction, but you can also change the refractoriness of part of the atria and ventricle, and so change the FF. When you use the more than 2, better is 2.5 mg per kg of sotalol, at this point, you are working on the isthmus, and so you prolong the FF interval quite more, and then you stop the tachycardia. So amiodarone, as you know, has different effect. I think all the four class of drug effect, but mainly is a class 3. The problem is toxicity. That's why we tried with sotalol, but wasn't good for this dog, despite he has a normal right ventricular function, but it still was in congestion. And congestive heart failure is not always a very good friend of sotalol. Not always, but very commonly there is some side effect too.
Okay, and last question, seeing the high ventricular rate at the presentation, did you consider any antiarrhythmic drugs with the IV administration or just oral administration?
We like to use the oral boluses to stop flutters because we don't think that this rate is enough to induce in this dog severe congestion, at least in a short term, and particularly hemodynamic imbalance. So we think that when it's a 2 to 1 conduction ratio, just like in this case, we think that using a chronic dose of imiodarone or sotalol is enough to improve quality of life of this animal. So if we don't have a real hemodynamic problem, we don't like to use IV drugs, particularly in a dog with underlying severe heart disease, congestion, and so on.
Okay, thank you very much. Let's see case 3.
Okay, let's finish with this case. This is a Pomeranian, 13 years old, and he's a mitral valve disease dog in a class D. He was on treatment with torsemide, benazepril, spironolactone, and pimobendan. He was referred first because of acute onset of weakness and tachyarrhythmias. So this is the ECG that is quite interesting in this dog. As you can see here, we have narrow QRS complex with irregular RR interval. You see, they are all irregular. And then you have P waves here here, because you see probably here, because the probably here, here, and I think that's the most visible. And if you try to see the P wave and you see that the P wave appears in all leads, it's very likely that these P waves are real, because my first understanding for this ECG was, this is an atrial fibrillation and these are just artifacts, because are very, random P waves. There are one here, here, but they are dissociated. All right, so if it's dissociated, so that means that this is a junctional rhythm. But junctional rhythm is usually regular. So why this junctional rhythm is so irregular? This is why we believe at the beginning we weren't sure that this was a real P waves. And so we tested also the 5' ECG, and we saw that this junctional rhythm was very irregular, just like a case of sinus arrhythmia. But we know that the P wave are dissociated, so cannot be a sinus arrhythmia, but is a junctional rhythm. So look at this class D animal. So he has a huge left atrium, a huge right atrium with a combined pulmonary hypertension type 2 and type 1. So usually is a precapillary and postcapillary together, and we really don't know if it's just type 2 or if it's also a concomitant type 1. So we weren't sure if the P wave that we saw were sinus or not. And so if you look at the inflow of the mitral valve, we actually saw the presence of this atrial kick. So the A wave, you can see it here, and this is dissociated. So this was real. So this is our first time that we really documented a junctional rhythm with isorhythmic atrioventricular dissociation and a type of synchronization that is type 1. So the P wave is going back and forth across the QRS complex. There is in why the junctional rhythm was so irregular, we really don't know, because the junctional rhythm is an escape rhythm, is usually very, very slow and usually very regular. This happened when you have escape junctional, as our first ECG reading when we did all the different junctional escape, and you can find on my YouTube channel. Or can be junctional tachycardia, since it was a bit fast. It's a junctional tachycardia with isorhythmic AV dissociation. But usually also junctional tachycardia has always a normal RR and regular RR interval. So it's very, very important to remember that sometimes things change. So we saw few cases of junctional rhythm that was irregular. So be careful not to rule out junctional tachycardia or junctional rhythm just because the RR interval is irregular. I agree that 99% of the time is irregular and you see atrioventricular dissociation, but you can have few cases where it is irregular. All right, I think we have 5 minutes for question. Manuela?
Yes, first question is ECG. In this one, so P waves present a low discharge rate. So TP interval is very, very long. Why in a dog like this, a class D mitral valve disease, the P wave can be so low in the discharge rate?
That's an interesting point that I want to discuss in this part of our talk. So since this dog is a class D patient, so he is on 4 drugs. He was in refractory heart failure. So why a dog like this has a junctional rhythm with a isorhythmic AV dissociation? I mean, this junctional rhythm is around 90, 100, no more than that. So why a dog like this has a so low sinus rate? So our answer is that this dog has a concomitant sinus node dysfunction. And actually the previous halter before this finding, he has sign of sinus node dysfunction. So it's a dog that has concomitant sinus node dysfunction and hence junctional escape, inducing this irregular focal junctional tachycardia. And that's the main reason why we have this type of ECG features.
Okay, last question is about the first ECG. So the puppy, the Labrador puppy. So in your fletched to the previous QRS complex. So if you look during the runs of supraventricular tachycardia, the atrial deflection is closed to the previous QRS complex. So usually P prime wave during focal atrial tachycardia is localized at the level of the descending part of the T wave or at the level of the apex of the T wave. Why in this case is so close to the previous R wave?
Okay, this is a good point because we analyzed this part here where it was a little bit far away, but then if you look at here, it was closer here, and this is the negative and so on. But my answer is that it's changing in the oscillation, so meaning that when you have EAD, you have this beat inducing this oscillation. And obviously the oscillation in this particular case are the P prime because it's an oscillation of the action potential of the atrial cells. So what happens is that you have faster rate, and usually when this faster rate is happening, is usually arising from the pulmonary vein. And this was the case because we know that we were very, very close on top of the left atrium, close to the ostium of the left pulmonary veins. So these leaves present into the pulmonary vein are area where you can have EAD, and some of them respond quite well to ivabradine, some other does not. So it's very, very important to remember that the presence of P prime on top of the T is usually considered the focal atrial tachycardia arising from the atrial myocardium. When are close to the previous QRS complex are more likely to come from the vein. From the vein are just faster because are very commonly EAD, and therefore they have very, very rapid oscillation.
Okay, so there are no more questions.
All right, so it's 8 o'clock. Thank you very much for your attention. And this was our last ECG round for this year. And we will, we will let you know for next year when we will do some others or some other seminar. And you can just follow us on our Instagram or on our Facebook, so you can be updated about our seminar. Thank you very much for your attention, and bye-bye.
Thank you, bye.